Removal of percutaneous ventricular assist device at separate and distinct session from insertion. Repositioning of percutaneous ventricular assist device with imaging guidance at separate and distinct session from insertion. A left ventricular assist device, LVAD, bypasses the left ventricle during the blood oxygenation cycle, making the ventricle work less during the systolic phase. The device is removed when the patient's ventricle recovers, an artificial heart is placed, or the patient undergoes heart transplantation. The arterial and venous cannulas are removed, and the external centrifugal assist device is discontinued and removed. This code can only be reported for the removal of an LVAD during a different operative encounter than the insertion, and is only used for a percutaneous LVAD, not an implantable LVAD. A left ventricular assist device, LVAD, is the most common type of VAD, helping the left ventricle pump blood to the aorta. A right ventricular assist device, RVAD, assists the right ventricle in pumping blood to the pulmonary artery and is typically used only for short-term, right ventricular support following LVAD surgery or other cardiac surgery. Report 33993 when the components of a percutaneously placed LVAD or RVAD need to be repositioned at any time other than during the surgical encounter for insertion. This code includes imaging guidance. Insertion of ventricular assist device, VAD, extracorporeal, single ventricle. Extracorporeal, biventricular. Cardiopulmonary bypass is required. For right ventricular failure, a pump uptake tube is placed in the right ventricular apex. A pump delivery tube is placed in the pulmonary artery. The pump is turned on and the patient is weaned off cardiopulmonary bypass. For left ventricular failure, the pump uptake tube is placed in one of the pulmonary veins or in the left ventricle apex. The arterial delivery tube is placed in the aorta. The pump is turned on and the patient is removed from cardiopulmonary bypass. The implanted pump is placed in a pocket formed in the upper abdominal wall, but outside the abdominal cavity. Tubes for the pump drive are brought out through separate incisions in the skin. The pump is started and the patient is weaned off cardiopulmonary bypass. The device is removed when the patient's ventricle recovers, a total artificial heart is placed or the patient undergoes heart transplantation. Should code 33404, construction of apical aortic conduit, be reported in addition to code 33975, insertion of ventricular assist device, extracorporeal, single ventricle? It would not be appropriate to report procedure code 33404 separately as it is a necessary component of the main procedure described by code 33975. Removal of ventricular assist device, extracorporeal, single ventricle. Extracorporeal, biventricular. Cardiopulmonary bypass is required. The pump is stopped. All the tubes are removed and any holes in the heart or vessels are closed. The device is removed from the patient's body. Cardiopulmonary bypass is discontinued when the patient's heart function returns. An intra-aortic balloon pump is often required to allow discontinuation of bypass. All wounds are closed. Report if biventricular support is needed. Replacement of extracorporeal ventricular assist device, single or biventricular, pump, S, single or each pump. The physician replaces the blood pump component of an extracorporeal ventricular assist device, VAD. The previously implanted pump, which was placed in a pocket formed in the upper abdominal wall, but outside the abdominal cavity, is removed. Pump replacement includes removal of the existing pump, insertion of a new pump, connection, dairing, and new pump initiation. Replacement of ventricular assist device pump, S, implantable intracorporeal, single ventricle, without cardiopulmonary bypass. With cardiopulmonary bypass, the physician replaces the blood pump component of an implantable, intracorporeal, single ventricle VAD, ventricular assist device. This may be accomplished without cardiopulmonary bypass, 33,982, or with cardiopulmonary bypass, 33,983. Pump replacement includes removal of the existing pump, insertion of a new pump, connection, dairing, and new pump initiation. Insertion of ventricular assist device, implantable intracorporeal, single ventricle. Removal of ventricular assist device, implantable intracorporeal, single ventricle. The physician makes a midline incision extending from the sternal notch to the umbilicus. Superiorly, the dissection is carried to the undersurface of the diaphragm until the apex of the heart can be palpated just lateral to the inferior phrenic artery and vein and carried well back into the retroperitoneum. The preperitoneal space is open to allow room for the device outflow valve and graft conduit. The muscular attachment of the right hemidiaphragm to the medial edge of the sternum is divided to allow room for the graft. A small incision is made and a tunneling device is passed subcutaneously inferiorly around the umbilicus, and into the pocket through the rectus sheath at its most inferior aspect. The tunneler is screwed onto the end of the drive line, which is pulled back through the tunnel to the skin. The drive line is not attached to the skin. Cardiopulmonary bypass is instituted using standard aortic and dual-stage venous cannulae. The inflow cannula is inserted through the apical cuff until the sintered titanium surface is within the cuff. The Dacron tie of the inflow cuff is secured and an additional plastic band and Dacron tie are used to reinforce the connection and flatten out the silicone cuff. Blood is allowed to passively fill the device and exit via the outflow valve. A partial occluding clamp is placed on the right lateral aspect of the ascending aorta and a longitudinal aortotomy is performed. The periaortic adventitia is left in place and a strip of pericardium is incorporated into the anastomosis. The apex and heel of the anastomosis are reinforced with interrupted 4-0 proline plate-getted horizontal mattress stitches. Inotropic support is started before separating from bypass and activating the LVAD. The device is switched to automatic mode after the cessation of cardiopulmonary bypass. Transesophageal echocardiography is used to ensure adequate ventricular decompression and a bubble study is performed to rule out a patent foramen ovale. A thermodilution cardiac output is performed and compared to the output from the LVAD. In the presence of severe coagulopathy, the chest may need to be packed open. The device is removed, 33,980, when the patient's ventricle recovers, an artificial heart is placed, or the patient undergoes heart transplantation.